Hey, Sean, good to see you. All right, why don't we go ahead and get started? Steph will join in a few minutes. I just wanted to have Caitlin take over for a few minutes just to show you some of the resources she's put together, and particularly related to the WIP, just kind of where everything is, because they're all cataloged now and up on a site, so you can access older ones and see the schedule. So do you want to walk through that for a few minutes, Caitlin?
Sure. Yep. So this is part of an effort to make resources and more of a centralized hub on SharePoint. So I'll share a couple links in the chat. One is the next several WIPs. So that's a direct link to a SharePoint site, and then I'll talk a bit about how to locate that. And this second link is a link to recorded WIPs. So they go back to about March. And those WIPs are also, thanks to Sasha and Katie's absence, part of the department rewind now, so you can catch them there. But those two links that I sent will directly get you to the WIPs anytime you want. And then let me back up into SharePoint. I shared this with research faculty yesterday, and I'll share it more broadly and continue to edit it. But this is a working draft of a hub of resources to help with research projects and contacts for that. So you can access this through Teams. There's a public team called Research Resources. And if anyone has trouble finding that and wants the link to it, I can send it to you. Then under General Resources, there's a WIPs tab. So that's where this is situated within SharePoint.
Great.
Any questions? I know there are varying levels of familiarity with SharePoint among us. Sasha being our resident expert for sure.
I just want to say it looks great.
Awesome, thanks.
It's nice to have all the recorded ones, because there might be things that weren't relevant to you initially that you could go back and see if anyone's spoken about them. So that's helpful. And if you have overall questions, as Caitlin said, Sasha's done a kind of tutorial for people just to back up and even understand what SharePoint is and how to get there and how it works with everything else in the department. So that's recorded and up there too. I suppose you have to know enough to find your recording about how to find everything, Sasha, but I know I reached out to you and you sent it to me directly. So for those of us who are many steps behind, you seem to be generally available to help. So thank you.
Definitely, yes. Anyone, if you have any questions, I'm more than happy to help. So please feel free to reach out to me.
Great. And then I just wanted to welcome Shira Winter. I don't know if she's had a chance to introduce herself to the group, but do you want to just say a quick hello?
Sure. Hi, everybody. I'm very happy to be here. I'm Shira Winter. I am a doctorally prepared nurse and nurse practitioner. My research focus is on the home health ecosystem and transitions of care, particularly as it relates to the nursing workforce. And I'm really excited to be here with all of you. So thank you.
Great. Thank you. Welcome. And I see Steph.
Hi, sorry, I am here.
Okay. Does anyone have any other quick updates to share?
Yeah. So for Emily is currently in DC for her Health and Aging Policy Fellowship orientation, has received her notice of award. So she is actually going to be funded for the CDA from VA. So we can speak about it now.
Excellent. Did she get assigned yet?
I'm sorry?
Did she get assigned? Like, does she know what committee or group she's going to be working with? Or that's
for Health and Aging Policy Fellowship. I think this is actually going to be, so if memory serves me right, as it's usually towards the end of your orientation when folks actually select their placement. So she's still in the thick of it right now.
Okay, great. Okay. Anything else?
Just, Sean, just want to highlight, and I think Will has said this, this is just a tremendous opportunity for anybody who is interested. Applications go every year, and if you really want to learn how the intersection between research and policy happens, this is just a terrific way to do it. And I think, Will, you can speak to that as well.
Sean, as you've said. But feel free to contact me, Alex, let me see, Bryn, and Diane, all of whom have actually done this, and Joan as well, and Joan Penrod, who has retired, but was actually, and also Greg Heinrichsen was actually before all of us who've done it. So yeah.
Okay.
So
Well,
plenty of
maybe when she comes back, we can put a panel together and just kind of, she can share what she learned and how it impacts her research, et cetera. And then we can have you and Alex and anyone else who's able to attend also. That might be a good way to kind of understand what it is.
Yeah, be happy to do that.
Okay. All right, and just real quick, so GSA is this week, and I think, Caitlin, do you want to describe what we'll do post GSA for people who aren't able to go?
Yes. So yeah, for all of you who are going to GSA this week, we're excited for you to share your work. And for those of us who are not, we thought it would be fun to have a whip session. So 2 weeks from today. That's sort of a blitz style recap of posters. So everyone who presented a poster will just share that poster for literally 2 minutes, blitz style. We'll have one question after each. And if you presented a paper or did a talk, you would just put up one slide. We won't be able to squeeze in everybody. So I tried to get a broad swath of people doing different types of research. So we'll have a nice mix of faculty and staff and MSTARs coming the 15th to do that. And if you have any questions about that, you can reach out to me. And I've been in touch already if you're there on the list. So anyone who has questions, please feel free to reach out, but I'm excited to see it. It'll be an experiment in whip style, so it'll be fun.
All right. All right, Stephanie, why don't you go ahead, get
Okay,
started?
Great.
Thank you.
And I was to Caitlin's remark about the new kind of blitz kind of thing. That's what at the faculty meeting I had said, we could do this thing called this quick shot presentation that surgeons do at their conferences because they don't have big poster hallways that we might at GSA, like where there's an auditorium. Surgeons like to talk by themselves and share their own. They don't want to share in glory with people like looking at posters. So they have 2 minutes. What do we have? We have 3 minutes to present our entire thing and then 2 minutes for question feedback. And that's all because they wanted to present. They just love to present. So my husband is a surgeon. I'm not knocking surgeons, but it was just something that I think that we should, that's really great. And it's hard for geriatricians and maybe palliative care to get everything down to 3 minutes, but it was pretty effective to get everybody going through really quickly to share work. So I think that's a great idea.
Great.
So I will share my screen. My disclaimer and confession is that I have a lot of things that I'm preparing for right now. And this one I have in links and in pieces to show you the works in progress. It will hopefully not be as disorganized as it feels in my mind. But it's most of, actually, I see actually a lot of our team is here. I thought they would be at GSA. So I apologize to my team. We are actually much more organized than maybe what it might come off in this 30 minutes. But the goal is to show you where we are with this co-management PEPR pilot and then where we're going and the bits and pieces that we have been pulling through to make it work. So I see Drs. Hung and Morrison here. So just, and Fred, as well, like all of you. So hopefully this will update you in ways that is cohesive. So I'll talk about this kind of work in progress and how this is developed for me, starting as a clinical educator, then an administrator, and trying to figure out how to study this program in a research way, and how kind of grappling with these pieces has been a challenge, but also something that's really fulfilling and very interesting. We don't have a clinical administrator or kind of work in progress, but in some ways, trying to build a program and disseminate it and study it has been it has been very useful to come to these meetings and hear how projects are being rolled out. Also looking at how we've been recruiting and growing numbers for this co-management piece. I will talk about our documentation analysis, of which there are many, and how we did that, trying to learn about qualitative research and using these documents to guide us in coding and themes and structure, and how to inform our clinical program has been really useful. And again, I still see patients in the office, so kind of having that reflective clinical time to relay back to the research team has also been a work in progress. I'll go over a little bit of our documentation analysis, or at least hopefully the links will work, and the interviews, and then the future pieces, which are not part of the particular PEPR, but the inpatient expansion and working with the surgeons and pulling it back to us when the patient is discharged from the hospital. Maybe I should.
Do you want to switch to the presentation mode? Is that what you're doing? Yeah.
Yeah, is that this one?
Yep.
So
yep.
right now, we have our team, oh, it's very blurry, presenting at GSA. And I just wanted to show you that we have a poster. So we are producing something to show our efforts. You don't need to see the actual components, but really the assembly of the team has been, this idea of looking at a program and understanding how do we show that it's a program that's useful, and something that's of interest to not just the research world, but also the health system, and the clinicians, the surgeons and medical providers, and the families that are involved, patients and families. The clinical team for Align has been a big component because they do actually all the data gathering. They are seeing the patients, and this is being translated into the REDCap database, where all of these components of each of the templates that we've constructed is being entered. The qualitative group led by Abigail has been looking, interviewing the stakeholders, the patients, the providers, the surgeons, and the geriatrics providers, as well as the various stakeholders. So this is a piece that goes into the same thing. Grant writing and having mentorship from the research group has been very helpful. Meeting with stakeholders and just having that overall representation from all aspects has been a really fruitful learning piece for me. And then also incorporating the learners that come through. So fellows and medical students have been, MSTAR, and then our fellows who are very interested in this, they shadow and see patients in geriatric co-management clinic with us, and then they realize they want to learn really the underpinnings of how we're doing this or why we're making this happen. As you may or may not know, Align and Align Care started as a high-risk program at the Martha Stewart Center, where we work with the patients that medical providers or teams identify as high risk. And high risk is a loose term for us because it could mean different things to different groups. With the health system, going into the in and out of the ED in the hospital is high risk because it's very costly and it doesn't look good on numbers. And those are the teams, especially insurance companies, that are very interested in knowing this high risk, high needs population. But from a medical provider, I mean, high risk is also somebody who's very taxing to your panel. They call you all the time with big and small issues. And there are things, part of their care that is not, they don't know how to address it. They don't know how to navigate. They don't know how to get the proper resources. So they're looking to you for that help. And so as Align grew, different groups of high-risk patients came into our care. And so Align Care is specifically this empowerment of the patients who are looking at surgery or considering surgery. There's something about their bodies that has changed that requires a surgeon to go in and make a physical structural change to their bodies. This is very concerning for older patients. They worry about their ability to heal. They worry about their ability to care for themselves afterward. They worry about whether or not it's the right choice for them. And so they want to talk with the surgeons, of course, but the surgeons don't always know how to talk with them about these needs. And so this is why the program exists, to meet those conversations that patients really want to have with their medical provider. And maybe the surgeon, although they are doing the surgery, is not always the best person, but maybe a geriatrician, because the patient's age, or a palliative care provider, and that kind of communication strategy is the best person to be in between. And so our goal to provide optimal, comprehensive perioperative care for these older adults is really what matters most to the patient, but also is the key component of geriatrics and palliative care. You know, what matters to you? It's going to change as you get older. As we know, it's always changed from when you're a little kid and Halloween is the most important thing to right now, where you're older and you realize there's more to life than dressing up in a costume and getting candy. So for our vision, we want to make this program a bigger thing. We have a small program. We're looking to grow it. We want to study the components and the feasibility and see if we can be disseminating it to not just our own Mount Sinai, different campuses, because now we have different hospitals, but also nationwide to collaborate with other institutions in different regions, because everybody has patients who are growing older. So to remind you, I don't even remember if I presented this last time, we have a triangle of care. We are the Aligned Care Geriatrics team, social worker, geriatrician, coordinator, nurse practitioner, your medical and your social, psychosocial, and your organizational. And we work with these two groups, surgeons and also anesthesiology, as well as the PCP. And largely in this communication structure, it's basically been surgeon and PCP, and maybe they talk, maybe they don't, but usually they're in their own silos. It's much easier, more efficient for them to just deal with, you know, the patient and back and forth. But really what we recognize for older patients is they actually need this better triangle of communication. They need this, and more of them will need this as our aging population grows and as technology improves, and you can have surgery for things you couldn't have before and do well. Our previous WIP had shown we have 3 aims. We're looking at who the patients are that surgeons are referring to us. These are surgeons that, you know, they want to do surgery on these patients and they feel these patients have a chance. And some of them are kind of thinking, oh, well, they're older, and I want to work with geriatricians, so let me try this. But some surgeons are actually thinking, I'm not quite sure if this patient is a good candidate. Let me send them to geriatrics so they can talk about it, because I have to see 20 other patients right now and I don't have time. We also want to look at the outcomes of each of these management interventions. And I will say that we are not restricting ourselves to a single type of surgery, which many co-management programs are. We have been open to urology, vascular surgery, general surgery, oncology, and renal transplant surgery. And so the things that surgeons are looking for in our qualitative interviews, we have found are different based on the type of surgery, the urgency, and the patient themselves. So this has been a very interesting aim for us. Aim 2, looking at the feasibility of the model by looking at the uptake of each of the elements. And so Abigail has kind of taught us how to really look at, you know, we have a referral process, we have the intake process, we have the patient visit, and then afterward, the data entry process. And each of these components is something that we want to examine to see what checklists, what kind of things have we hit and where are the problems. And this has become very important to go back to the clinical team and talk to them about, you know, why is the visit so long and you missed all of these things at the same time, to kind of see this, is this a feasible thing? And so as a researcher looking with the research hat to see, you know, why aren't these components being done? Why are we failing? We can talk to the actual clinical providers and see from their examples why this maybe isn't feasible or structurally sound. And then the last aim 3 was to look at the facilitators and barriers of really implementing this full structure, and how this program could be disseminated elsewhere, expanded. Let's see, I'll start here. This is just a list of what do we actually do with our patients when we see them. We have on the left, this blue picture with the hands, the 5 M's, or sometimes 4 M's if you're looking at simplicity. Geriatrics looks at these components for all patients in general. If you're going to explain what does a geriatrician do, you can use these 4 or 5 M's. What matters most: mind, multimorbidities, mobility, medications. This has been studied often in many settings. And then on the right are the additional psychosocial components that our team, Align team, has identified as being important for our high-risk patients. Look at all of these other things that are tagged, closely tied to the ones on the left. What motivates a patient to achieve these goals? What is their mental health state? Because we acknowledge there's not enough mental health support in general, so this is often a need. The ability to make medical decisions, reasoning, advanced care planning, coordination of care and understanding how to navigate a really complicated health system is difficult for us. Somebody who has some memory challenges, it would be much, much harder, especially somebody who doesn't know the new systems that have come in place. And then also their management, their financial health insurance troubles. So we have condensed it into kind of 7 interventions, and we have classified when we see the patient, is this something that is a maintenance because it's stable, or is it something that we have to really actively go through? I didn't time myself, so I'm going to make sure that I try to get through. So this is the big overall slide. We have made a simpler lucid chart structure, so I apologize to my team because they know that a simpler one exists, but I just showed you this one. This phrase 1 is where we see the patient before they go into surgery at all. We are seeing them, and we are advising them on how do we improve any of these 7 components to make their care even more stable. So when they go into the OR under the knife, they have the best possible chance of walking out or coming out of it with fewer complications, shorter length of stay, fewer episodes of delirium, no falls, no medication, polypharmacies, other things that many patients are often afraid of, or providers are afraid of. Phase 2 is when they're in the hospital. How do we look at that? How a geriatrician or geriatrics team can really optimize and make that care best. And currently, Morningside actually is working with the trauma surgery group and really has a model of how this can be a successful relationship. And the majority of co-management programs actually in the country have to do with this phase 2, this inpatient piece, because that's also where it's easy for health systems to understand the impact of, the financial improvement and optimization of having a geri team on board. And then phase 3 is when the patient leaves the hospital. This is often a very scary thing for surgeons because they don't want to have readmissions. They don't want to have numbers repeat show that their surgery has failed. This 30-day readmission is super important for them. And so having a geriatrics team there to examine what is that transitional care? How do we make sure the patient doesn't go back to the ED for a dehisced wound or medication confusion, or simply not having the healthcare services in place? The CHA services, the short-term visiting nurse services, never showed up because there's a shortage of VNS now because of COVID. So these kinds of things is what geri and aligned care would be especially instrumental in assisting. This is the page that has all the links because I didn't have a chance to put them in. So this is basically our works in progress, and I'm going to see if this will take us to the appropriate places. Right now we had 76 patients that we put into a table. Right now I think it's over 114. But as I said, we have different types of surgeries that we're looking at. The majority, as you can see, of our patients are from kidney transplant, and that's simply because we started with this program, kidney transplant first. As long as 2016, we have a very long-standing relationship, and the championship of the surgeon, Dr. Lerner, is the strongest. So she refers the most. You can see this wonderful chart that Moritz put together, our distribution of patients overall, by race, educational attainment. You can see the comparison between the groups. We are looking at these components, insurance status as well, looking at their dementia diagnosis, just with the thought that perhaps we would be, given we're geriatrics palliative care, this would be a strength of our ability to really work with patients who have cognitive impairment, knowing what their cognition status would be, or at least their diagnosis. Surgery type, you can see the difference. You see the distribution. I mean, renal transplant is majority of our cases, and we do have a few kind of very minor like ophtho or bone marrow, but those are like cataract and other other surgeries or biopsies. And then we also are looking at their frailty. So this is a study in how do geriatricians and surgeons identify frail patients, and how do we, after we see them with a comprehensive geriatric assessment, classify or stratify these patients in terms of frailty, and what would their outcomes look like afterward. We have our cognitive component, physical scores, so functional status, IADLs and ADLs. We are looking at nutrition and overall other markers of frailty. And I will just slowly let you see the things that we're looking for. These are based on pretty complex templates that we use on all of our patients. The visits are quite long, take sometimes more than an hour, and we'll have to see patients back to complete the visit. But all of this is entered into REDCap and pulled for this. I'm looking at the wrong screen. Oh, here we go. So with that, basically, this is from the patients that are referred to us that we will see. We also have been talking we have also been talking to the providers themselves and patients and surgeons, geriatricians, surgeons, and surgeons to kind of assess how their experiences have been with the program. And this is an example of one of the interview topic guides that we've been using for our patients. This one actually, this is the link for the patients actually. I meant to put one for the providers, but right now, this has been a process that we've been working on where our team will look at, questions that we feel are important components to hit for our patients, and how we will interview these patients individually to better identify their experiences. So tell me a little bit about yourself and your experiences. What brought you to see the surgeon? When you initially met with the surgeon, how was it? What was it like, and what happened after you met with the surgeon? You discussed the surgery. How did that prepare you? So this is part of the different topic guides. We have one for the patient, we have one for the surgeon, and one for the geriatrics team. And so each of these will be recorded and transcribed, and we have our team looking at the codes and topics that are pulled from it so that we can better understand how to continue to tailor our clinical part. The other piece for our works in progress that we'd like to update is that we have a series of meetings from an administrative piece where we have different stakeholders meet to discuss different aspects of the program. And this is necessary from a program clinical standpoint, but also administrative. And the research team has been looking into identifying themes on how they mesh with each other, each of these meetings. So we have 4 meetings that are regular for Align Care. The interdisciplinary team, which is focused on the actual program components and how to explain workflows and efficiencies of the program itself. When there's a new instrument that we put into the program, the team discusses how this is feasible and able to be provided within the hour of seeing the patient. We also have an advisory team with the stakeholders and the supervisors who identify matters that are kind of health system level that trickle down into our clinical space, and how these things are feasible or not feasible within the daily structure. We also meet regularly with the surgeons themselves to work out referral processes, logistics, iron out what the expectations are for each of these process maps. And we have feedback and regular meetings in this capacity. And then finally, the research team, which meets to sharpen the kind of way that we're doing our intervention and how we're capturing the information. So this is an example of our memo synthesis. So going through every single one of the meeting logs and coming up with common themes and ways of analyzing the method or the purpose of each of these meetings. This has been a piece of our documentation, and to synthesize that, we have also created a timeline of how this has come about since the start of the program. This has been an MSTAR students, speaking of learning, an MSTAR students actual project to create. So since we had started in July 2020, all the way to April 2022, how each of these components above the line is a program element change. So identifying from our documents, each of our meetings, what is a program element change? What is a management level change? What are instructional changes? That's all on the top piece. And then below the line are the management changes, things that from an administrative piece we have been making. as part of the development and roll out process. And this is something that we're hoping to write about, the way that this is, because we feel that although it's for geriatric co-management, for programs in general that are developing clinical programs that are being studied, this may be a way of kind of looking at how to feasibly implement something and roll it out. And you can see based on the time gaps in between, examples of patients and specific patient cases, numbers, workflow, and then the stars are showing links to other references of other dates on the timeline. We can see when different team members were entered, when the PEPPER project was accepted, when new instruments were introduced, REDCap database, and how the program began and was launched, REDCap data entry, and increased publicity. If anybody has questions, please let me know. I'm just going to take us through a few more. The data dictionary was another piece because we recognize when we work with the surgeons and we want to know about their outcomes. I think this is not the right one. When we want to know about their outcomes, we want to know that when there's a complication for surgery, we are using the same language. And so this connection with the clinical piece is very important, so that when we're mapping it out, we have the same, okay, well, what I can do, I'll just say that that data dictionary exists. And then this is finally our interventions table. We have the components of the visit here on the left, frailty, multimorbidities, overall global health, functional status, mind and memory and mood, very much those 7 interventions that I showed you in the beginning that we look at when we see our patients. And we have specific validated tools that we are using to extract, evaluate each of these components. We also have what we define as what is normal, abnormal, or acceptable, optimized or not for each of our patients. And then the common recommendations that we make for each of our patients. This was something that from our first WIP was cited and is still actually being cited by our mentors and stakeholders, that this is a very assessment heavy program, and we understand that. I think geriatricians often do a lot of assessments, and that's part of when you're older, you have more complicated things to really discuss. And so the comprehensive geriatric assessment is it's a huge exam. And so we want to make sure that these are pieces that are studied. But at the same time, the idea of what is the intervention, the outcome side is very important, at least from a program proving and research piece. And so the idea of fleshing out this column of what are the geriatric guided management recommendations has become much more of a focus lately. From an administrative standpoint, looking at instruments to show that something is worth doing is also a struggle for a clinical team to really tell them you have to do this survey because it's part of it. It's a validated tool, and it's something that is easier to study as an outcome. To kind of work with a clinical team and help them understand, what is it why would they use this amount of time in their clinical data to make it work? This kind of efficiency dialogue is also something that has been very important for me learning about how to make things work. Sometimes when you see a patient, you do all of these things, not everything needs to be recorded. And so the idea of, what is efficient for patient care, but what is efficient for research has been a boundary that has been muddled kind of during this process, but it is very enriching to know that it's important to understand when we're evaluating clinical programs. I hope I'm making myself clear. And so these are all of the platforms that we're using that really helps us to study this. And this is basically what our works in progress has been. All of these elements, we've been very busy. It's been very interesting to see. For phase 2 and phase 3, these are things more from a programmatic standpoint that are not part of the PEPPER pilot, but are instrumental in the success and maintenance of this phase 1 anyway. Phase 1, just to remind you, is that outpatient. Before the patient even goes into surgery, we see them as a geriatrics team, and we make these recommendations on how to optimize these 7 components here in green. and how to make this patient the best possible candidate for fewest complications in a surgery because they are older and they're frail. And then the decision for surgery and for them to get the surgery. Right now we have inpatient care at Morningside Hospital with the trauma service that we are looking to try to roll out some kind of structure for inpatient for Mount Sinai Hospital. We have, as you probably know, we have a concurrent geriatrics team that sees patients. And so there is some structure, but identifying and figuring out what these components, what is necessary for successful translation is also something that we will be looking at moving further down the line for feasibility and barriers and facilitators. And then Mount Sinai West is another group where surgeons, especially orthospine, has shown a significant interest. So kind of balancing out the needs, the clinical needs and the interests of the surgeons is something that is also part of the program aspect that we are looking at. And then finally, the transitional care management. So when they leave the hospital and they go home, this is another piece that we are looking at to make sure is streamlined before we can say that this whole program can exist in a stable manner. Okay, so this is my last slide, and just to thank, this is a very large team. There's so many people that are involved, and I think that this is something that is we'll continue to work on and make a piece of this project in its entirety. So thank you very much for your attention. Sorry that it has to be in this structure, but I hope that it generates a lot of questions. And that is all. Thank you.
Don't apologize. That was great. This is a works in progress. So wherever it's at, it's not supposed to be like a grand rounds type thing. So that was wonderful, especially how you were able to explain it. Just for my purposes, can you repeat again what the main outcomes are that you're looking at?
I'm gonna probably fumble it, but there have been the targets of, I mean, studying the ability to the feasibility of implementing this program, the success piece. We have a clinical program that we're trying to study with. Let me think about this. There's yes.
Sorry, go ahead.
You want to rescue me?
You want to
I
finish
was
it?
going to say I have multiple outcomes in my head, but I feel like I'm always redirected. I mean, the ability to implement a program like this, each of the components that we're trying to do in studying the patients, I feel like that feasibility, which parts of it is part of the outcomes, but we're also looking at surgical outcomes from a grander standpoint of reduction in the complications that happen after a surgery. That's kind of where I see it. But Will, I would like Will to also step in and explain.
Yeah, that's a perfect answer. I think, for the Pepper pilot, given it is a shorter duration of setting up the project, it is actually mostly looking at feasibility, issues related to adherence to different elements of the assessment and intervention. And as we actually move on to look at more about what is the effectiveness of this intervention, that's when we actually also have to look at, what are the clinically important outcomes. So Fred has actually looked at the NS-QIP related outcomes that is actually being tracked, so nationwide for surgical outcomes. But at the same time, particularly also for geriatrics as well, so some of the outcomes that would be important may be actually a little bit different. So discharge location, functional loss, that type of thing are the things that we are actually looking at for outcome. And as you pointed out, for the outcome part, it's as we are thinking about the larger effectiveness trial, that is actually one part that we do have to nail down in order to actually power the study. So that is actually currently in the works as we are collecting some data as to the outcomes that we have first looked at and see what actually makes sense to be tracking as main outcome of the final study. Fred, anything else?
Nothing to add. Thank you.
Thank you. And I'd also wanted to mention the difference in the surgeons when they're looking for what they think is an outcome. the kidney transplant surgeries, for example, patients don't get a kidney until, 7 to 10 years. They may have to wait. And when they come to us, they're in their 70s. And the idea of being alive to get a kidney is a big question. So they use our data, our progress note much differently than the other surgeons. They actually look at our cognition and functional status, and it's basically, do they list or not list the patient? And so that's something that they use much differently than the other surgeons who are already considering to take that patient to the OR.
Other comments and thoughts from the group?
I was curious if you might say more about the way that you said it was a loose definition of how the patients are identified. It's people who the surgeons think are high risk. Do you think that because you have the renal transplant group that's obviously totally on board.
Mm-hmm.
What do you think? Do you think you might have to adjust that loose definition a bit to capture more people in some of those other surgical practices?
Yeah, it's a good question, because every surgeon, I think the way that they're screening the patients that part has also been tricky to explain. We want to capture pre-frail and frail patients using the frail scale, because we felt that was the easiest way a surgeon could have time to tease it out. So the level of fatigue in walking a certain distance, the resistance they have in going upstairs, their ambulation, the number of illnesses they have, and loss of weight. So that's FRAIL. So all of them, the surgeons are supposed to use that. If a patient gets 1 point in any of those areas, they're considered pre-frail and therefore a candidate to be considered. And then their age cutoff has also been another that we've been using. Renal transplant has been giving us more than 80% of our patients come from kidney transplant. And so they had been using 65 years and older, but we had to change it to 70 for them, just to balance out the rest of the surgeon recruitment that we were looking at. Ortho spine, for example, is another group that has become very interested, and they, based on their numbers, Dr. Chun had said, maybe we should take 70 years and older. So kind of changing the age cutoff for some of this is another thing that we were looking to balance. But looking for a way for surgeons to screen has been tricky. Another piece that I didn't mention was there's the preoperative medical group, the POMA group, that does the majority of the surgical pre-surgery assessments at in our health system. And they just have a general scheduling database that we are now able to take a look and see, and we can pick out patients from there as well, or we can screen patients in that way. So that's another different way. The surgeons, we try to be as concrete with our criteria. So we have age and we have the frail scale, and then the surgeons use them at the way that we have meetings monthly to make sure that they're understanding the way of the screening should be consistent across, so that we can maintain that. But yeah, I think that it's interesting. One other thing that the surgical oncologist, the Surg Onc, Dr. Cohen had remarked was, for him, for patients who have cancer, there's also other things that they use for their own kind of screening. They say, well, they meet the components, but we also have this patient that's not sure they have a cancer, and the treatment that's available, surgery is one option, but not surgery is another option. And my outcome, or my request from you as a geriatrics palliative care, is to really talk more with them about those other outcomes. Maybe it's not the surgery that is best for them and what matters to them. And so they're asking for something different compared to Dr. Davino, who maybe wants to do a hernia repair, and it's like more of a yes or no question. So I think that also kind of ties into that recruitment and that loose kind of identification for referral, which is also very interesting to study too.
And ultimately may also tie into the outcome part in terms of surgical decision-making, accordance with wishes of patients and family, et cetera, et cetera.
Yeah, I mean, I can see why thinking about the outcomes then is very complicated. Because if there's the outcomes related, like when you first set up the presentation, to surgery complications, readmission in 30 days, ED visits for infections, like things like that, that would be compelling, from the health system, financially and that type of thing. But then if it's around like discussions about even having surgery at all, then none of those outcomes would be relevant. If they decide, not to do surgery, you would have to have a whole different set of outcomes. to
Of
assess
outcomes.
That.
Yeah. And the patient outcomes, if you look at what does the patient think is an outcome of a surgery, sometimes it's whether or not they're going home or to a rehab, whether or not they can walk and go to the Dominican Republic where their whole family is, or have to be staying in the country because their medical care is better served here. And recently in speaking to, there's a patient advisory board, and one of the persons actually said, I expect the surgeon, I expect the surgeon to do the surgery. What I'm really worried about is the anesthesiology, the outcome, the complications of that medication, but I expect the surgery to be successful. And there's so the outcome definition in a patient's mind is very different from what our health system or even the surgeon is thinking, or the geriatrician. So that's why I do struggle with the idea of what is the outcome, but I understand it depends on who you're talking to in the frame.
It sounds like the larger efficacy and effectiveness trials, it might make sense to be more coned down in terms of the population.
Like people who are definitely going to get a certain surgery.
Or like the same practice setting, the same organ,
Yeah.
Mhm.
just because what matters to the different populations is so different and
It's
the
so different.
trajectory is different.
Yeah. And I recognize that we tackled a very big fish. It was most of the co-management programs choose to work with one surgeon and one type of surgery. Ortho hip fracture, where a lot of co-management places started just looking at that piece and they could focus on an outcome more specifically. But we are trying to look at surgery for older patients, older frail patients. And this part is a little, it's a lot looser, a lot more gray, and trying to figure out that outcome is challenging. But I think we started the program from a clinical mindset. We wanted to work with the frail older patients of Mount Sinai Health System at the Martha Stewart Center. And that's what drove us. It is much more kind of patient focused driven rather than the research piece or the administrative piece. And so we're grappling with how to show this as an effective model, because we're hoping to make this to disseminate in this way. I don't know if anybody from the administrative side has anything to say, but that's where we are looking.
So one big divergence part is actually about renal transplant surgery. So we were actually not going to, we were going to separate it out into either a different project and not include in the sort of project proposal. We think the other surgeries are probably a little bit more similar. Intra-abdominal, vascular, orthopedics. So these are kind of major surgeries that would invade the body cavity in some way, that would introduce stress. And I think that from that lens, it may be able to group certain surgeries together.
I don't want to pick
I
on.
actually have
Oh.
2 other questions, but I don't
Oh,
want
yeah.
to, if other people have thoughts, please chime in or raise your hand or something. So one question is, so as you're working with so many different surgeon types and things, when you go to even propose doing something like this and kind of working with them collaboratively, do they give you a sense of, we would implement this if it showed X, Y, Z? I mean, you're not getting additional reimbursement for doing this. So then are there different metrics that from their
surgeons are looking for?
They would say, yes, we'll take this on as long as you can show this certain outcome, and then you could because ultimately you're going to, if it works,
Right.
in your mind, you're going to want to then make the case to make it standard.
Right.
And so do they tell you in advance, kind of, people want to do pilots all the time, and this is like what we say it needs to do?
I mean, that was the reason why we were looking at the frail scale as the easiest thing for a surgeon to screen, and age. We wanted to make it at the barrier as low as possible. Every surgeon we work with, I always have a 1 hour kind of meet with them and go to their clinic and watch how they see patients in the outpatient setting and do their needs assessment in person with them. And I always ask them, what are your metrics? What are you hoping for? What do you need from us? And they are vague about it. They have metrics that they enter into NSQIP, like Will and Fred were saying, that they are standard across, the surgical pieces, and then they have their own. Urology has their own versus general surgery, but they don't have, a thing that they really need. That we try to make the barrier as low as possible for them to join as a surgeon. And then I suppose they just hope for, the length of stay, no readmissions, no complications. Those are all pretty uniform across all of them. I think they recognize at this point that geriatrics, and they have older patients, geriatrics is a team that will help them more than hurt them. At least that's what we're looking at. I see, Chris, this is something that, surgeons don't want us to convince a patient to not want the surgery. Of course, they want their numbers up, but they want their numbers up and also successful. So that's the part where they always want us to help, and they don't have a definition of their best outcome with us involved.
Got it.
Yeah.
One thing I've learned with the liver transplant folks is that, and there's a lot of overlap with that
Yeah.
surgeon population,
Renal transplant, liver.
is that they really don't care about healthcare utilization outcomes. Like they don't care about readmission or ER visits. Like, good, stay longer so that we can be successful. Sort of thing.
Oh, that's great. Interesting.
Mm.
My only other question was in terms of some of the outcomes that would be kind of post discharge and going home, and you assess kind of where they were in function and things like that. Do you also have ways of assessing like who their caregiver is and how functional they are or likely to support them? I know a lot of people here are very interested in that caregiver side, and if that would influence outcomes in a way that you could not to expand your set.
We're looking at.
Like someone who's going to help.
No, that's true. We had talked about
get them to do the stuff they're supposed to do and take what they're supposed to take.
Right. That's a huge piece, because especially of cognition. I mean, we were talking about this at our last group meeting about interviewing or looking at caregivers as part of the qualitative interview process. If they have cognitive impairment or an challenge with functional status, they need help with their IADLs or ADLs. Because we haven't moved to phase 3, I think that's also but it's something for older patients. Often they will need that bigger support. Will, I see.
Yeah,
because we just talked about this, the caregivers as well.
Stephanie, I think you also, part of the assessment is about social vulnerabilities as well, which is the big part.
The social worker will look at
part
this.
of the evaluation that you are actually doing. So in that vein is actually looking at how likely somebody is going to be able to go home and have all their needs met in terms of what those vulnerabilities are, and putting in place plans that could actually be that could actually support the older adult throughout their surgery journey. So I think mapping some part of that to be able to have a way of measuring that would be quite important. So we should actually think about that.
That's right. The social worker has their own psychosocial determinants of health, and then also following along with the CMS survey. So there are pieces where they look at, housing, insurance, and formal or informal caregiver supports, that level of need. And then in the transitional care management part, I do know that surgical teams often don't have a social worker on their inpatient team for discharge. And so when we do our TCM, transitional care management follow-up, we probably should have a social worker also be checking in on those components, especially knowing that for discharge, in general, our inpatient readmissions for geri and palliative care has been up since COVID. And one of the pieces that Dr. Martine Sandin had said was probably, VNS services are really falling through. They're not as available as they used to be. And so these kinds of temporary, what we call CHA services are not the same level that they used to be. And so having that identify, I think that understanding that better and what is left over for family can step in or neighbor or friend, and what other managed long-term care is available. I think that's definitely something we should make sure, if it's not, I think it's already in our survey for social work, but we will make sure that's part of it.
Just in terms of the caregiver piece, I was just going to add one piece of pilot data that might be good to have is just and Deborah and I have been struggling with our own caregiver recruitment, is just knowing what percentage of your population physically has a caregiver at the visit. Because they're very hard to recruit once if they're not physically there.
You mean in the room during the
room.
evaluation?
Yeah.
Who's in the room when it happens? Yeah, that's great.
That's a great point. Just to start keeping track of that, so you have like some proportion if you're going to move that forward. Interesting.
Thank you so much.
Can I also add I hope you guys can hear me. This is such an interesting conversation. Sorry, I'm just sitting at the airport. Just another thing that's coming up with the geriatric team. Oh, thanks, Caitlin. Is that there's some challenges knowing how to organize interventions for patients who are outside of the Mount Sinai system. And so the caregiver piece and sort of drilling into some of these things on the clinical side, I think for them, it's hard to know what the next steps are for what feels like to some of the team, a fairly large cohort or, proportion of patients. And I think that's an interesting issue too, around, where the program can intervene on which patients' behalves, in trying to develop a more sort of overall integrated and supportive system for patients. So I think we're trying to keep track of that on the qualitative side. And I don't know if there's a way to also, think about, we've been thinking a little bit about the geography, the data we're capturing around geography and sort of the coverage that's possible. So I wanted to just bring that piece in too. Around sort of how the program interacts with some of this information.
I know I'm thinking about your triangle of care, and if the PCP piece of it feels like the weakest link, as it were, maybe making it just a line between who of the Martha Stewart Center is getting surgery. Like, how does this type of care, how does this going on top of the geriatrics PCP piece, like how would that work? Kind of like the Falls Clinic, like sort of like a geriatrics on steroids.
Yeah, definitely the communication with the primary care providers, especially if they're external to Sinai system, has been challenging. So if we are struggling with that, we are also trying to see more geriatrics, see if we can recruit from the Martha Stewart Center to ease that component.
Okay. All right, we are at time. Thank you so much for sharing this. This is great, and it's great to see it at each stage. So thank you for sharing this information, and we'll definitely look forward to getting an update further from you guys.
Thank you so much,
Stephanie.
Thank you. Take care.
All right. Bye, guys. See you next time.